A very warm welcome to the subscribers of Pulmonology Read Aloud for another session of lung function test series. This time we are going to talk about lung oscillometry testing in the most simplest method ever. Let's talk about lung oscillometry and understand it in just 10 easy steps. Let's get started. So what is a lung oscillometry test? A lung oscillometry test involves an impulse generator that produces impulse in the form of sound waves. Now these sound waves superimpose in our normal tidal breath, and by superimposing with them, they can travel a distance in the lung based on their frequency. The oscillations of these impulse-shaped signals penetrate the respiratory tract based on various depths. Now, the smaller frequencies or frequencies such as 5 Hz can pass the entire lung, while the larger frequencies may be able to pass only up till the large airways. This gives us a varying measure of the entire lung as well as of the large airways, and the resistance can be incurred from them. Also, this resistance can be differentiated from the lung reactance, which is a term that we'll be discussing in the coming slides. And using these two main measures, we can ascertain whether the lung is giving more resistance, whether it is more stiff, whether it is more compliant, and we can use this data to clinically tell us about the disease in question. Lot of times people are confused on the terminology that is used for oscillometry. Remember, oscillometry or lung oscillometry tests comprise of all the known numericals that you know of. It means forced oscillometer test, it means impulse oscillometer test, it means oscillometer testing. So basically the main approach or the blanket term that is used for all oscillometric tests is LOT or lung oscillometry testing, but it can be divided into types and subtypes based on how is the impulse generated. One of the way of doing that is by measuring the type of impulse. If we produce a sinusoidal impulse, a sinus wave impulse, which more or less matches our normal tidal breathing, then this is called as a forced oscillometry technique. Also here, in forced oscillometry technique, we give mono frequencies. So at a time, we may give 5 Hz, then the generator will produce a 7 Hz, 20 Hz, 30 Hz, varying depending on whom are we testing. Whether we are testing children, where we may have to measure from our 7 frequency till 30, or we are measuring adults where 5 to 20 is sufficient enough. So these are called forced oscillometry techniques. If we send a square waveform, and this square waveform is sent in multiple frequencies more or less simultaneously, so giving the whole frequencies together to the patient, 1 to save time, 2 to make it more easier for the patient rather than giving him various sound frequencies, then this is called as impulse oscillometry. Both FOT and impulse oscillometry may give you different readings, but the interpretation, the mechanism of testing is more or less similar. This is how the equipment looks like. The equipment includes something to generate the sound waves, in this case a loudspeaker, a fresh air inflow and a low pass filter. Through the pneumotach, these waves, these sound frequencies are then introduced into the patient's respiratory tract, and by the measurement of the flow and the pressure, we're able to ascertain the resistance. Now, all of the sound producing equipment may not be a loudspeaker. Some of the equipments use a pump to generate these signals, some use a speaker, some use a vibrating mesh. So amongst the various oscillometry devices that are available in the market, one of the main difference is in what is being used as the producer of sound waves and what kind of waves are being produced. Are these sinusoidal waves or are these square waveforms? What are the advantages of oscillometry? Advantages of oscillometry over spirometry are multiple. But does oscillometry totally replace spirometry? So far the answer is no. Oscillometry plus spirometry used in conjunction gives us a lot of information, and going forward probably we'll have more and more utilization of either both of these techniques or individual techniques based on what are we looking for. But I believe that oscillometry will not be able to completely replace spirometry, which has already gotten so much into the system, but it is a very good adjunctive which must be used when available. The advantage of oscillometry is that it does not require a forced maneuver. Since it's just normal tidal breathing, anybody from a child even 2 to 3 year old till an elderly patient, a patient on a ventilator or a tracheostomized patient, or any frail, weak patient, a bedridden patient can also do this test. And this test can be used in advantage to find out about the clinical status of the patient, to measure the lung functions of the patient, and also just like spirometry to see for a bronchodilatory response or a bronchoconstrictor response as in provocation testing. One main use of this technique is that it has been implicated to be one of the main techniques that can be used to a certain small airway disease in addition to the helium dilution or the nitric oxide technique. So lung oscillometry has numerous advantages, and these can be added on to the benefits of spirometry also in many circumstances. This is a very beautiful table, and if you are an exam going student, I suggest you take a screenshot of this slide. This table, which was taken from Dr. Sandeep Salvi's paper in Breathe 2015, shows the main differences between spirometry and oscillometry, FOT or IOS. So if you look at it, the main principle, as I said, is forced oscillations of various frequencies which are pushed into the lungs, and the pressure waves are used to measure the resistance and the reactance. So what are the main parameters that are we measuring? In spirometry, we've all been used to measuring FEV1, FVC, the FEF 2575, the mid expiratory flow, the peak expiratory flow. But in oscillometry, the terminology that we are measuring is impedance or Z, resistance or R, X or reactance, F or resonant frequency, and AX the area under the reactance curve. In spirometry, you need a lot of cooperation from a patient, and you need the patient to understand. In oscillometry, this is not much required. A spirometer uses forced exhalation and an oscillometer uses normal tidal breathing. Just like spirometer, expect some inter-observer variability, expect some inter-device variability, and that's where we use a term called coherence to see whether our inter-test variability is high or low, and that can be used as a good qualitative measure. The oscillometer can measure differences in the central peripheral airway and the resistance across the airway. It has a different cutoff for bronchodilator response. While 12% is used for spirometer, oscillometer uses a response of 40% for resistance or reactance to be called as a positive bronchodilator response. And as I said, it can be used also for bronchoconstrictor responses. It gives a very good insight into lung mechanics. It has almost now reached a place where we are able to standardize the methodology, and Do we need reference values in an oscillometer? Recently, some studies have been done, including a lot of work on oscillometer by our very own Indian revered researcher and professor Dr. Sandeep Salvi, and there is some insight that maybe for an oscillometer we may not require reference values at all, because it is not age, height, or ethnicity or race dependent. So this is going to come up in a huge way, and for now reference equations may or may not be required in oscillometer vis-a-vis a spirometer, which definitely requires a correct reference equation to interpret. Point number 5 to know in an oscillometer is what measurements we use. So as I said, there are three main terms that you will be seeing in a lot of reports. One is respiratory impedance, which has two components, which is respiratory resistance and lung reactance. And what it uses mainly is the Ohm's law to define resistance as change in pressure on change in flow. Impedance, the term, means to impede. So if you look at it plainly, when we are measuring impedance, we are trying to see what is the pressure, what is the force that is causing an impediment of flow of the impulse to get in the lungs. So if the impulse has been given to a patient and there is something that is impeding it, whether it's in the airways, it's in the parenchyma, or it is the elastic recoil, then that can be measured, and that tells us about the clinical circumstance. We look at this picture taken from again Dr. Salvi's paper in ERS, which shows us that whether you use a sinusoidal wave of FOT or a square wave oscillation of IOS, we are trying to measure the resistance at throughout the lung level through R5, only large airways R20, or the difference of R5 minus R20, which should roughly give us the resistance in the smaller airways. He uses a very beautiful analogy for us to remember this, and says that just like FM sound waves or frequency modulated sound waves can only reach up to a particular level. So if you're in India, for instance, the FM radio of Delhi would serve Delhi and the FM radio of Mumbai will serve Mumbai, or in the US, an FM radio of Texas will serve Texas and Jersey will serve Jersey. Similarly, the frequency modulated waves of higher frequency like R20 can only reach up to a depth, so only serve the large airways, whereas the AM modulated frequencies, just like that, the lower frequencies or R5 frequency can actually penetrate up to a large distance. So this beautiful analogy that he's used helps us to remember the R5 and the R20 equation. Coming to the values, coming to the terminology, the first terminology that we must remember is resistance. And as I've already spoken about, resistance is the resistance to the impulse. Now this resistance may be in the respiratory tract, in the trachea, in the large airways, in the small airways, or in the lung or the chest wall tissue. Now when we are measuring resistance of the total airway and the resistance of large airway, we deduce a resistance of small airway. Normally in a healthy adult, whether this frequency is 5 or the frequency generated is 20, you will not see any change in the resistance, because there is no resistance, because the airways are normal. If there is a patient who gets airway obstruction, and this airway obstruction is in the large airways, then if you remember, then R20 is supposed to increase in the large airway. So you see that the R5 may not go as high as the R20, or your curve that you pick up will just go up. If a patient has resistance in the small airways, then you remember that R5 minus R20 reflects the small airways. So at resistance 5 minus 20, this number is higher than the normal one, so you see a higher resistance. And this is how we use resistance to interpret the clinical scenario. Look at this oscillogram, and lot of values that we read are written here. We'll be coming back to this again and again, but we'll look at it at one go. And you see, this is the resistance, this is the frequency, 5, 10, 15, 20 and further. This is the graph that we get for another variable that we call as X or reactance. So when we read the resistance and we plot another value which is called reactance, we get this line. We'll be talking about this terminology called resonant frequency, which is the point where this line goes on from a negative to a positive. And we'll also go through what this triangle means, which is called AX. For now, remember that if this triangle AX becomes bigger, it enters an abnormal range. That means if this normal line shifts towards the right, it reflects abnormal. And if this value resonant frequency, which is normally between 7 to 12, shifts to the right, then we will get an abnormal value. Now let's try and understand what these actually mean. We first start with what is the resonant frequency. Normally, when you are giving a frequency, there are two properties of the airways and the lungs that cause a hampering of the impulse wave. One is called the inertance of the airway, and the other is called the capacitance of the airway. And the inertance and capacitance of the airway may not be equal, because the periphery may exhibit another level of resistance and the central airways may exhibit another level of resistance. So when both of them they equalize, the total reactance becomes 0, and this is called as resonant frequency. This is a very important terminology, and it will become more clearer as I give examples. But it's important to remember that if the resonant frequency changes, there is some abnormality, whether obstructive or restrictive, but there is some abnormality. And as I showed in the oscillogram, the triangular area or area of reactance is also very important, because that reflects the compliance of the lung. The compliance which we can easily give an analogy of the ability of a balloon to grow bigger and bigger and bigger. So the compliance is reflected with AX. The compliance, the small airway patency for the air to go across, that is all related to AX. And so it has a very close relation to smaller airways, R5 minus 20. So this area of reactance is also an important value. Since I've been talking about inertance and capacitance and it's a bit confusing because we haven't spoken about reactance, I now introduce the term reactance. Reactance of an airway includes two components, the inertance and the capacitance. Now reactance is really a more of an imaginary or intuitive figure. Now elastance or capacitance of the airway means the energy return property of the lung, the property of the lung to have a recoil, or the property of a lung to not be stiff. So we usually think about reactance as this elastance or this capacitance of the lung as the ability to recoil. However, it's important to know that either, even if there is fibrosis or there is emphysema or there is small airway disease, the reactance still changes in either of them. So reactance may not just mean the ability to recoil. Reactance with capacitance may mean the ability to store energy and the ability of the lung for elasticity. So together that can contribute to a reduction in patients with fibrosis a reduction in patients with hyperinflation. So this value x5, which is more of a deduced value from all the variables that we mentioned, this x5 reactance helps us to understand whether this lung is more fibrotic or whether this lung is more hyperinflamed. And the more negative or the more higher negative value of reactance, the more abnormal the reactance is. So the two parts, whether inertance of the larger airways is affected or the capacitance of the periphery is affected, that gives us the variability in reactance. What is the clinical application of these rather confusing terms? When we talk about impedance, we are talking about resistance plus reactance. When we are talking about R5, we are talking about resistance of 5 Hz frequency, which reflects the entire respiratory tract. When we are talking about R20, we are talking about resistance at a 20 Hz frequency, which reflects the large airways. When we are talking about 5 minus 20, we are talking about small airways. The reactance talks about the lung elastance, the lung compliance, and the lung heterogeneity, and it also talks about small airways. The area under the reactance curve, AX, indicates what is happening distal to the airway or to the periphery of the lung, and if the AX increases, shifts towards the right, we know that we are going towards an abnormal value. The resonant frequency, where the minus and the plus balance each other, talks about airflow obstruction and restriction because it changes in both. And there are newer terminology being put forth like X5 inspiratory and X5 expiratory, which may in future tell us and distinguish between obstructive and restrictive components. From this slightly confusing terminology, let's go to the clinical application and let's try to make sense of what we've been talking about. First of all, we must know how to perform this test. So this test is usually performed in sitting position. It can also be performed in lying down position in certain individuals who are bedridden or who are on ventilators. However, the sitting position is preferable. It's also important that your patient should sit with legs uncrossed so that the extrathoracic pressure is not increased, and the mouthpiece of this device is at the level of the mouth of the patient, so at a comfortable height, because we don't want the patient's neck to be excessively extended. There is a filter and a mouthpiece that is placed in the mouth, and there should be a tight seal because we do not want air leak. And the most important point about oscillometry testing is that the patient has to support his cheeks. Now, these cheeks can be held firmly either by the patient or by an assistant who can hold these cheeks from the back. This is very important to avoid the dispersal of the pressure of the sound waves, and so this patient must support the cheek properly, otherwise we would get artifacts. So when we start the test, we just tell the patient to perform normal tidal breathing in a resting state. We perform the testing for around 30 to 45 seconds. And when we are doing this, we are actually giving him almost 120 to 150 sound impulses and pushing them in the lung. And from these, we will determine the reactance and the resistance at frequency 5 to 20 Hertz. When we start interpreting our data, we look at two most common values or two most common equations, and then we can deduce the other as well. Firstly, as I said, this is the resistance, so the frequency. So resistance at frequency R5 and R20 is normally equal in a normal individual, so you would get a rather flat like of a line. If this patient has an obstruction which is in the distal airways, the smaller airways, we spoke about how R5 minus R20 increases. So we would see a higher resistance at R5 and a nearly normal one at R20. If your patient has a proximal obstruction which involves the large airways, then R20 will also rise as much as your R5 may rise. And if your patient has a restrictive lung disease, you may not get much of a change here because there is no resistance at the level of the airways. The second thing that we look at is the reactance or X. Remember, I told you about resonant frequency and the area under the curve, this triangular area of reactance. So now we look at these two. If your patient has obstruction, you see this resonant frequency has shifted to the right. You see this area of reactance has also become shifted, and the X5 is more negative as compared to what a normal patient will have. If your patient has a more proximal obstruction in the large airway, it does not affect the reactance because it's a measure of inertia and capacitance, which capacitance is described more in the distal airways, and this is the part which reflects the inertia, this is the part which reflects the capacitance. So if your patient has restriction, then this part will change. In obstruction, it may remain the same. In a restrictive lung disease, as I said, the resonant frequency is changed, the X5 has become more negative, and look at this AX, which is markedly increased. So what is happening is the capacitance is getting affected, and so the reactance is also changing. Let's understand the ranges of normalcy as given. While literature is not uniform on the normal ranges because the devices are different, their interpretation is different, and each device has a different value to be taken into consideration. Broadly, the European Respiratory Society mentions that if the measured R5 is more than 120 to 125% of the expected R5 or the predicted R5, then there is obstruction. There are also other variables which have been mentioned by different devices, mentioning resistance to be more than 140% predicted, or reactance to be described with a predicted equation. So if there is increase in R5 more than 140, according to this, there will be a peripheral obstruction, and you can calculate the small airways index and the lung reactance to deduce whether these are normal or abnormal. Things have become more simpler, clearer after a lot of research and dedicated research on lung oscillometry results by Dr. Salvi, and this is his editorial in ERJ 2023, which mentions that there may not be any need of predicted values, and you could use a fixed cutoff to differentiate between a healthy and a disease state. However, this has only been deduced in adults. For children, we may still need those equations because in children, the compliance, the resistance changes with age. In adults, however, something which is more a matter of simplification and can be very useful is that any R5 more than 4, R20 more than 3, R5 minus 20 more than 1 will be abnormal. X5 minus 1 is normal, more than minus 1 is abnormal, and AX should be around 4. Remember, these readings are in centimeter water per liter per second. There may be some oscillometric devices which give a reading in kilopascals, and in that case you may have to divide this by 10. So 4 R5 in centimeters water may correspond to a result of 0.4 in machines which are giving you reading in kilopascals. As we all know, spirometry is used to check reversibility, so oscillometry can also be used for that. Broadly, it's been mentioned that any change in R5 more than 40% and AX by 50% reflects a good bronchodilator response. However, again, based on the machine, based on the technology, the data differs, and so ERS recommends the thresholds in both adults and children to be a 40% change in R5, a 50% change in X5, and 80% minus 80% decrease in AX. Let's start reading certain oscillograms and get to some examples now. So as I said, normally R5 and R20 should be equal. So this is the normal curve and this is the normal reactance curve, where X5 would be here minus 1. This would be our AX and this will be our resonant frequency. Let's go on and read further. So now let's look at what happens in COPDs and asthmatics. The content for this slide has been taken from the presentation by Dr. Sandeep Salvi, and I'm really thankful for Sir to make these concepts more understandable and simplified for us. And I am also presenting the facts and the concepts which have been explained by him largely so as to present this video. So in COPDs, if you see, the R5 in this patient is increased. The R20 here is nearly normal. And the AX has become more negative. The resonant frequency has shifted more towards the right. So definitely, because the R5 has increased, but the R20 is normal, we can see that R5 minus 20 will be much larger. So COPD, we all know that small airways are affected in COPDs predominantly. So if you see, this typically shows how the small airways are affected more as compared to the large airways. And the area under the reactance and the resonant frequency is increased. But after the patient is given bronchodilator, this significantly improves and shows a this definite reduction post bronchodilator in the AX component, with some reduction as well in the resistance component. Let's look at this example from an asthmatic patient, and you see that the R5 here also is high, the R20 is also high, and the R5 minus 20 is also high, along with a change in the AX, a change in the resonant frequency and the reactance. So definitely here as well, we see that there is a rise in R5, R20 and R5 minus 20. So all the airways are involved, the large airways, the small airways, the peripheries, and post bronchodilator we see a much better response as compared to the COPD. So such examples may be helpful to distinguish between disease entities, and as we go with the new spirometry guidelines, it has been clearly mentioned that spirometry should not be used to diagnose a disease, but rather to diagnose the physiology going on in the lung. So the role of FOT here is really remarkable. Coming to pure small airways obstruction, this example is courtesy Dr. Sandeep Salvi's presentation, and here you see another change. This patient's R5 is increased, R5 minus 20 is increased, the AX is shifted to the right, the resonant frequency is shifted to the right, and the AX is more negative. So all of these are happening together in a patient with small airway obstruction. This is one of my own patient's reports. So here they've plotted for his age the upper limit of normal of resistance. You see this patient has more of a flat R5 and R20 resistance. Even the AX is normal and the X5 is normal. The resonant frequency is slightly shifted. Normal would be 7 to 12 Hz and this one is around 15 Hz. However, this will be reported as a near normal. Let's go to more. So this is normal. Here, if your patient has an obstruction, then R5 is very high. If the patient has a peripheral obstruction, a small airway, then R5 on 20, this difference becomes really high. In case of the reactance, you see if this is the normal predicted line, the more the restriction, the reactance, look at it, it's highly abnormal. So these lines will help us estimate the actual condition going on. There are very good resources available and examples available on this. One is an open deck of presentation slide by the ERS, and you can get this freely accessible on the ERS education portal for more practice. There are also technical standards for respiratory oscillometry which were published in 2020 in ERJ by Gregory King et al., which can be read to understand which equipment you have and what would be the standards of performance. So that's all that I have today for you. I hope this video helps you understand oscillometry better and that you can use it more and more in your practice. Keep reading, keep sharing and subscribing. Bye bye till we meet next.